Good morning and welcome to the 35th meeting of the Health, Social Care and Sport Committee in 2025. I've received no apologies for today's meeting. The first item on our agenda is for the committee to agree to take items 4 and 5 in private. Do members agree to take these items in private? Thank you. The second item on our agenda is to take oral evidence from 2 panels of witnesses as part of the committee's Stage 1 scrutiny of the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill. The first of this morning's panels will focus on Part 2 of the Bill, which relates to the functions of medical reviewers and death certification, and in policy terms is completely unrelated to Part 1. And I welcome to the committee Dr George Fernie, Senior Medical Reviewer and Caldecott Guardian, Healthcare Improvement Scotland Certification Review Service, Anne-Marie McAlpine, President of the Association of Registrars of Scotland, and Jim Murdoch, who joins us online, Senior Manager, Wellbeing Planning and Performance, East Ayrshire Health and Social Care Partnership. And we'll move straight to questions, and Sandesh Gohani.
Thank you. Now, Declaration of Interest of Practising NHS GP. Good morning, panel. I suppose, as the convener said, this has nothing to do with Part 1 of the bill. It's completely separate and it's a vehicle to get this into legislation. So, I suppose my question is, why do we need this? Could you give me an example of when this would be necessary?
Yes, it's a very small number of cases, but an interested person review allows somebody with a connection to the deceased person to have a review of the medical certificate of cause of death. And up until now, you've been ineligible, you've not been allowed to have one if a review has already taken place.
Could you give me an example of how that would...
So if somebody is unhappy with the content of the MCCD, which you'll be familiar with completing yourself, then they would normally have an opportunity to ask questions about that and have my service conduct a review. But until now, if a review has already been conducted, we're only talking in 10 years about 2 or 3 cases, but they've not been allowed to have that because of the primary legislation within the Certification of Death Scotland Act 2011. And we identified in my annual report of 2018-2019 that we would welcome the possibility of people being able to have a review. So a very small number. It just seemed inherently unfair that they could not have a review because they'd had a more basic one, and then they had additional information that they wanted us to test for them.
So if, and you're right, I've had to fill these out, and I've also gone through a level 1 investigation to see, to check what's happening, and they were quite thorough. The investigation that occurred. So what is the difference between a level 1 investigation and when somebody comes and asks you for a review of the death certificate?
Well, the interested person review is a more detailed level 2 review. There was some slight blurring during the pandemic in that both reviews, you'll have a conversation with the doctor, such as you've already experienced, and also go through in a structured manner the content of the MCCD. The difference with a level 2 review is that there'll be some corroboration of what you're saying by way of looking at the clinical record as well. Pre-pandemic, we would check that we had the right patient with the CHI number, the Community Health Index number, and we'd check that we had the correct doctor by asking you about your GMC reference number and making sure that that was correct. And we would also look at the emergency care summary, which included medication and allergies there. With the pandemic, we started to be allowed to look at the electronic key information summary as well. So that strengthened the information, and it was more focused, and we were able to ask more detailed questions of the certifying doctor. We've also now been able to access the clinical portal in virtually all of the territorial health boards, and that would be part of the level 2 review, and we would just confirm that what is being said is accurate, that's there. So it's a better, more detailed review, the level 2 review. The other thing with an interested person review is that we do try and ascertain from the applicant what the basis is for them seeking this to try and address as thoroughly as possible the concerns that they may have. They're not obliged to do that, but we just think it's more helpful to them, and it's greater transparency as well.
Okay. Jim, if I may turn to you. So we heard from Dr. Fernie that this is possibly 2 or 3 cases. So I assume that you have enough resource and capacity to deal with this?
So I'm representing the Health and Social Care Partnership in East Ayrshire. So this is not something we see commonly. Uncommon, I would suggest. So given that it's a fairly limited numbers that we would see, we would seek to support this process just within our existing capacity that we have. I suppose our role really is to support families at that stage of life. So we have a strategic priority around dying well in our strategic through our integration joint board. So that's about supporting people towards that stage of life and post-death as well. So we would broadly support the provisions in this bill to support confidence and accuracy in the death certification process, and that confidence that families can have if they have any concerns. There's now a wider opportunity to raise these through the provisions in the bill. Thank you.
Thank you. And just on the point of confidence, obviously in the 2000s there wasn't a great deal of confidence in the process, and that has been robustly improved as time has gone on. But I suppose that is there going to be a time limit that you set for this review, and what would count as new evidence?
Well, the time limit as it stands would remain. It would be within 3 years of the certificate. So again, the material should be reasonably accessible within that period. So we would be happy with that continuing as it has. That's not been an issue with it. We've had a total in 10 years of 13 certificates that we were not able to review. 10 of those had already gone through the Procurator fiscal system, and there's no proposal to change that. I don't believe it would be in the public interest for perhaps conflicting views to be expressed if that was the case. So it's only 3 cases that we've identified that we would like to have been able to do a review to help the relatives who'd suffered a loss that have requested that. So we don't see it as any great burden as far as the service is concerned, and we think it's of benefit to a small number of people, but it's obviously incredibly important to them to have the certificate as accurate as possible. The 3 primary drivers remain the same with the Death Certification Review Service: to improve the quality and accuracy of the MCCD, to derive better public health data, which of course became particularly important during the pandemic, and to strengthen clinical governance. And again, those are the same principles that we would seek to continue with.
Okay. And my final question, Mr. Anne-Marie, what is the opinion of registrars in Scotland?
The Association of Registrars in Scotland would support the proposals. We don't see it having a very great direct impact on the work that we do day to day, but if it's an improvement that is going to help our colleagues at DCRS and Healthcare Improvement Scotland, then we support the measures.
Okay. Thank you.
Carol Mochen.
Thank you, Convener. I'm just wanting to have a few questions about if a reviewer rejected applications. So just to ask, to understand how that might happen, what reasons the rejection might come on, and how they might communicate that with people who have applied?
Well, the main reason that we would reject it just now, as I was explaining, is if the case has already been reported to the Procurator Fiscal. So we think that should be dealt with by them to go through that process that's there. And we would communicate that as sensitively and as quickly as possible to the applicant and give them a clear rationale for it. There's a clause within the current Act that we can reject it if it's vexatious.
Yeah,
We've never had to invoke that, at the inception of the service, we discussed, well, what would vexatious be? And we thought, well, we hopefully will find out, but we have not. I mean, people just have not done this for any spurious reason. They maybe have got hold of the wrong end of things, and they maybe been more concerned about the care that was delivered to the deceased person prior to their death, but you can understand why it is they've got that concern. And I say we've always attempted to be bereaved focused in regard to any applications that are there, to be as sensitive and as accommodating as possible.
Okay, so it's not something that you feel, if the Act changes would increase, you think you could manage it in a similar way to you do now?
I believe we could manage it in a similar way. The only reason that we can reject it would be if there's duplicated requests that are there. But I don't believe it's likely that would be the case. The whole purpose of change is to be more open and to try and help relatives come to an understanding of what's happened, typically to their loved one, so that they can follow what is within the MCCD.
Okay, thank you. There was one other thing that came to my mind, just to understand if it happens or if this Act would help that, is the extent to the sort of consistency across Scotland. Is there anything there that we need to consider, or do you think that happens quite naturally?
I believe there is consistency. We've, over the 10 years that the service has been in existence, we've had a more structured approach to the annual reviews that we have with the territorial health boards, and we try and focus the review that we go to with what's been taking place and the educational resources that we have available by which we might be able to support them. I think one of the things we would have liked to have seen is mandatory training for especially younger doctors coming into the service, but there are so many competing demands on their time that that's not been possible up till now. We've worked in conjunction with NHS Education Scotland, NES, to deliver educational materials on their SAD website support, death website that's there, which really is an excellent resource, especially for doctors that are in training.
Yeah, no, that's helpful. And in terms of safeguards, just to make sure that reviewers are, consistent, you feel, is there anything else we should do there?
Not, I believe, within this. We have peer review within the service of the medical reviewers. We have an annual sample of the certifying doctors that we review. We review around 12% in total of non-procurator fiscal deaths that are there. That appears to be having the desired effect in that the not in order rate, the metric that we use, has gone from just over half, some fairly minor administrative errors, some more significant, gone from just over half in the first quarter that we launched the service to around 18% at the moment. Okay. And because of the rollout of the electronically completed MCCD, which we anticipate happening in this coming year, 2026, in secondary care, we think we should get another step improvement with that. So we are on track to deliver what was asked of us, I believe. Also, there are not undue delays. If you look to our neighbouring jurisdiction, there's been some criticism of delays with the medical examiner service that's there, whereas we have been able to deliver it real time with a very small breach rate of the 1 working day for a level 1 review, 3 working days for a level 2 review, and I'm not aware of any significant delays in regard to funeral arrangements as a consequence of that.
Okay, that's lovely. Thank you, Convener.
Thanks. Can I just pick up from where Carol Mawkins left off there? So how should the reasons for rejecting a review be communicated to interested parties?
I think they should be communicated clearly, transparently and as quickly as possible to them. I think it's unlikely that we would be rejecting it. The only sort of situation that I would envisage that might happen is if there are two parts of a family where one is unaware that an interested person review has already been completed. But it would depend on the individual case, because the other members of the family may have different reasons for seeking that, and that is why we suggest it would be appropriate to have some flexibility with it, because there may be situations where actually further detail has been communicated and it would make a difference to the review that we complete.
And would you support having a formal appeal process for rejected reviews? And if so, how would that work?
If you, as somebody qualified in both law and medicine, I would always support an appeal process that's there. I think it seems unfair not to do that. How that would work, I don't quite know, but in principle, I would always support an appeal process.
Okay, thank you. Elena Whittam.
Convener, and good morning to the witnesses. A death can be a very troubling time for a family. And in some of the submissions that we received in our call for reviews, there was concern round about the possibility of any delays happening with this new procedure. So I'm wondering if you can give us some reassurance that the new process would cause minimal delays or no real delays in the system?
I mean, it depends upon which stage you request an interested person review. The majority are post-registration, and we would have 14 days in which to undertake that. So I don't really think that's going to cause a problem. If it's pre-registration and there's no reason for people not to do that, they obviously cannot go ahead with the funeral arrangements. It's very tight doing it within 3 days and gathering the information in, speaking to the relevant professionals that are involved. So I mean, it's the same issue that's there just now, but I don't believe that it's more likely to cause a problem, the new arrangement.
And recently there's been the introduction of the advanced registration procedure. Do you foresee that that would still be available in these circumstances, or is there anything that would prevent that from happening?
The advanced registration procedure, that's not new, that's been there since the start of the service, and it's mainly to accommodate the minority faith groups, the Muslim and the Jewish community. So we have around 60,000 in the Muslim community, I believe, and about 6,500 in the Jewish community, who have very similar requirements, burial as soon as possible before sunset or within 24 hours. So we really try and do our best to allow that to proceed. Now, the only reasons that we cannot grant advance registration is if clearly the case should have gone to the Procurator Fiscal. So that, again, that's not going to change with that. So that's the main impediment, the possibility of that happening. If the certificate is substantially in order, which I think is a phrase probably that I coined originally, then even if we know that there may be an amendment required to it, that doesn't stop the advanced registration going ahead, and the same would apply with the new arrangements there. So I don't see it being a problem with that.
Okay, that's very helpful. And finally, for myself, I'm wondering whether witnesses agree that clear guidance and processes should be developed that would help to inform those who are requesting an additional review. And how do you see that working in practice? Because obviously it's a change. A lot of people don't know it exists anyway. Yes. And how should we communicate that to individuals?
Well, Anne-Marie might be better to answer that, I think, sorry.
It's about education. It's about making people aware that the process is available, and just giving good guidance whenever you find yourself in those circumstances, and signposting to DCRS for the more detailed assistance that bereaved families or relatives need.
And would that maybe take place when a registrar is dealing with a bereaved family, and there's maybe things that are being said in that meeting that leads the registrar to believe that there's maybe an avenue for this type of review to be requested?
I've not had that experience, but I could see that might be a situation that a registrar could find themselves in, yes.
Okay, and Jim, from a East Ayrshire Health and Social Care Partnership perspective, you spoke about the Dying Well strategy that's in place. How do you foresee those that are working within the Health and Social Care Partnership being able to communicate this new review process to people effectively and support them in it?
Yes, thank you. So I think it's always helpful to have clear guidance and have that well communicated across our communities and our workforce as well. I think we need to do everything we can to raise awareness of the process, and if families do have concerns, what the options are now and the wider options under this bill. So there's work we can do through our communications work. We can do work across our workforce in terms of raising awareness and providing information and guidance and all of this as well. So I think the awareness in our communities, I think we could probably do more to raise awareness of these rights and develop that understanding. We would do that in the course of our work through our ongoing support to families when they're family members at this stage of life, but more broadly just as part of our workforce development and ongoing learning and development work. Thank you.
Thank you. Very helpful. Thanks.
Just picking up on that, Jim. So currently, does East Ayrshire Health and Social Care Partnership have policy guidance about how to inform families of their right to ask for a review?
So I would imagine there'll be broad information there. I would have to come back to you, Convener, just on the detail of that. Where our workforce are supporting families at that stage, and there will be that support and information and guidance provided, just in terms of the relationship between our staff and the supported person and family there. So I think the point that's raised about the awareness there and how we communicate that, I think there is more we can do just more broadly around about this, and I think that there's an opportunity here to do that through the
should this bill pass? Yeah, but I guess what I'm trying to establish is there currently policies and procedures for informing families about how the law currently sits in terms of their right to ask for a review?
So I'm not sure. I have to check. I'm not entirely sure if there's actually a policy there to state that. What I would say is that it would be part of our support for families to be doing that just in the course of our work.
So they would be given information currently
yes.
on this, so indeed. This wouldn't be something new to East Ayrshire HACP.
No.
Right, okay. Thank you. David Torrance.
Thank you, Convener. Good morning to your witnesses. Can the witnesses set out the rationale behind the 2011 Act exempting the MCCD from being subject to a request for an interested persons review if a death has been investigated by a Procurator Fiscal, and how many cases would such a scenario apply to?
The rationale was that we could come to a contrary view to the Scottish Fatalities Investigation Unit in regard to the MCCD, and we don't believe that that would be in the public interest. There would be a loss of public confidence if we had contradicting views with that. It's a different sort of investigation that the Fiscal does. We would tend to look at normal deaths, as it were, expected deaths that were there, whereas they would be looking at deaths where there may be the possibility of criminality that's there, or concern about the level of care that was provided that would potentially merit a fatal accident inquiry. We have a small number of deaths. It's running about 3% at the moment that come to our service that we advise the doctor should have been reported to the Procurator Fiscal in keeping with the COPFS, the Crown Office Procurator Fiscal Services guidance. So I think it's important that we keep those separate. In answer to your question about the numbers, as I say, we did do a search in our electronic case management system, and there were 10 cases that we were unable to do an interested person review because they'd already gone to the Procurator Fiscal Service. with the interested person review, you have to bear in mind there are different outcomes from it. One of them might be that there's no change to the MCCD, that we believe it's in order. The other is that we would recommend that there is a change to the MCCD, and that's done through national records. There's a process that is possible to do that with. And the third alternative is that we advise the doctor concerned that they should report the matter to the Procurator Fiscal. This may be several weeks, even months, or exceptionally a year or two after the death. But if that is the case, that would be our advice, and doctors have always been willing to do that when that's been our recommendation as a consequence of the interested person review.
What are the risks that could arise if a certificate from a Procurator Fiscal cases are not subject to any further scrutiny?
That relates more to the care that was administered to the deceased person prior to their death, the investigation that was there, whereas our function is primarily to ensure that the MCCD content is as accurate as possible. So it's different functions that we have there. We do work in conjunction with the Scottish Fatalities Investigation Unit, and if they've conducted an investigation but they've got concerns that the content of the MCCD may not be correct, they'll direct the doctor back to us for advice about a possible change to that. So it's not that we work in complete isolation, but we're very much aware of our respective purposes with that.
And finally, Convener, should the Scottish Government consider revisiting this exemption in future reforms? Are witnesses sympathetic to the argument that removing this exemption would strengthen confidence in the process of a death certification?
I'm sorry, I don't understand that question.
Should the Scottish Government consider revisiting the exemption in the future reforms in 2011?
The exemption for, as regards the Procurator Fiscal. If the Scottish Government was minded to do that, it could be done. It would have resource implications. Again, we don't have a coronial jurisdiction, as do our neighbours within the other parts of the United Kingdom. So it would be a radically different approach to that. We certainly could work more closely in cooperation with the Crown Office and Procurator Fiscal Service, but that would be a different arrangement to the one that we currently have. I can see advantages and disadvantages with that. I'm a visiting professor at the Centre for Contemporary Coronial Law at the University of Greater Manchester, so I do have an understanding of the alternative approaches there. The one that we have in Scotland has served us pretty well since the country came into being. So, as I say, I think it would be a wider policy decision you'd be talking about.
No further questions.
Paul Spinney.
Thank you, Convener. One of the things that's really concerning is public awareness in this reform. So what further action is needed to make sure that the public fully understand the cremation process and feel reassured that all necessary checks have been completed, particularly when a death has been certified in another part of the UK?
It's always been a principle that was accepted that we should respect the arrangements in other parts of the UK. So I don't think that has changed. That is the policy that was promoted within the associated statutory guidance along with the Act. And obviously what we don't want is undue delays. Typically you'll have an arrangement where a coroner's inquest has been convened and then it's been adjourned, and it's to allow for the burial or cremation arrangements to go ahead satisfactorily with that. So it's just trying to be bereaved focused, I believed.
Okay. Do you foresee any risks in relying on certification from other parts of the UK?
I think there are limited risks with that, but if anything, the processes that are there are more akin to what existed before their medical examiner system came into being. Half of their deaths, as I think I said earlier, go to the medical examiner and half go to the coroner. So I would hope that there were adequate arrangements in England, Wales and Northern Ireland for that to not be a significant problem.
Okay. Do you think there needs to be any specific data sharing arrangements in place, or is there anything that you would recommend?
That might be something for the local authorities to answer better than I can do. The situation appears to have worked well thus far, and we do have 10 years' experience now. I mean, you'll be aware that prior to the service coming into existence, we had crematorium referees and we had 2 doctors as signatories to that. The new system with the revised medical certificate of cause of death seems to have worked pretty well in conjunction with the crematorium managers and the different local authorities. So I'm unaware of there having been any issues with that in answer to your question.
No problem. I just wondered if Mr Murdoch or Ms McAlpine wanted to add any comments in relation to this.
No further comment on that, no.
Maybe from a local authority perspective, Mr Murdoch, if you've got any thoughts on specific guidance or data sharing processes that you think might be helpful.
So thank you, Sardine. I think we would be broadly supportive of this measure. Again, to try and reduce any additional requirements at this stage in relation to cremation. I think good communication and data sharing would be important, just to ensure that any concerns or risks are mitigated there. But we would support this measure and build on the cross-border authorisation that's wherever possible. So I think this provision takes a further stage in terms of an additional review from that process. So hopefully makes that more straightforward and again reassuring for families at that stage. Thank you.
So just to be clear, no specific recommendations from anyone on further guidance or processes that would be required at this stage? Okay, that's helpful. Thank you.
Finished? Grant. Can I thank the witnesses for the attendance at committee this morning? And you are now free to go, but committee will continue working as we're running slightly ahead of schedule. I'm going to move to agenda item 3, which is to consider one negative instrument, the National Health Service General Dental Services Scotland Amendment Regulations 2025. The purpose of the instrument is to amend the National Health Service General Dental Services Scotland Regulation 2010 to allow health boards to include the name of a dentist on their dental lists on a provisional basis where that dentist has not yet completed mandatory training where required by Regulation 5A, and to amend provisions relating to the requirements to obtain the prior approval of the Scottish Dental Practice Board before carrying out care and treatment. The Delegated Powers and Law Reform Committee considered the instrument at its meeting on the 9th of December and made no recommendations in relation to the instrument. No motion to annul has so far been received in relation to the instrument, and I believe Sandesh Gohani wishes to make some comments for the record.
Thank you, Convener. Just declaration of interest as a practising NHS GP. Given the policy objectives and the movement to a high trust, low bureaucracy, I'd be interested to know what sampling is taking place when we are looking at a proportion of practices to ensure there is compliance. In the same way, we've just had death certificates discussed here, and we sample back 10% of death certificates to ensure accuracy. Moving on to the mandatory training part, over this, the idea of getting people into work, dentists, is something that I fully support. And being given a provisional basis for a period of 6 months is on the face of it, a very good thing. My questions around this is this NHS only, or does this include private work? So can a dentist take the 6 months and go and perform private work? And is there any oversight of this dentist over those first 6 months? So those are my only questions, but in general, I do support this move to ensure dentists are working here in Scotland.
Okay. I propose that committee does not make any recommendations in relation to this negative instrument. Does any member disagree? No. Okay, thank you for confirming agreement. And I'm going to briefly suspend the meeting until we go back to agenda item 2. We will continue agenda item 2 by taking oral evidence on the non-surgical procedures and functions of Medical Reviewers Scotland Bill from the Minister for Public Health and Women's Health and Sporting Officials. And I welcome to the committee Jenny Minto, Minister for Public Health and Women's Health. Supporting the Minister on Part 1 of the Bill are Rachel Coots, lawyer, Owen Griffiths, legislation team leader, and Alison MacLeod, lawyer for the Scottish Government. And I invite the Minister to make a brief opening statement.
Thank you, Convener. Thank you for the opportunity to support your consideration of the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill. I have some opening comments about Part 1 of the Bill concerning non-surgical procedures. I have some comments about Part 2 of the Bill, and I hope you're content for these to be made at a later stage in the session when you are considering evidence for that part of the Bill. I would like to start by reflecting on the issues that we are seeking to address with Part 1 of the Bill. The issue was brought home to me and a number of other members last year at a round table organised by Miles Briggs, MSP, where we heard some harrowing experiences from people who had been seriously injured after improperly carried out procedures. I think that you have heard evidence in the last few weeks about exactly this. Whilst many Scottish people undergo popular procedures with little thought to potential consequences, you, like I, have heard that adverse consequences can include necrosis or vascular occlusion, burns or scarring, and in the worst cases, sepsis, blindness or death. I don't say this to be alarmist or to malign the many reputable providers of these procedures. I say this to remind us all that there are serious risks to the public, which this bill seeks to address. Turning to the bill, this bill is robust but proportionate, and it seeks to ensure that those who choose to undergo non-surgical procedures can do so safely. The bill contains substantive provisions which will make the public safer. It does so by making it an offence to provide these procedures to those under the age of 18, which I hope we can all agree is a sensible and important step. It also makes it an offence to provide procedures out with permitted premises. Permitted premises will be safe, hygienic settings subject to regulatory oversight and from which healthcare professionals provide or manage services. The involvement of healthcare professionals also supports safe and appropriate prescribing and will enable those healthcare professionals to intervene in the event of complications. If this bill becomes law, it will be an offence for procedures regulated by this bill to be provided, for example, in the back of a taxi, to be given to teenage children, or to be delivered at a fizz and filler party in someone's home. Having discussed the main intent of this bill, I would like to highlight some particular issues that I think may be of interest. I am, of course, happy to address any of these issues in more detail during questions. I know I've said a lot about what happens when things go wrong. I also want to reflect on some of the dedicated and highly trained practitioners, not just in the already regulated medical part of this sector, but also amongst those in the broader beauty and aesthetics sector. I and my officials have met some of the practitioners who gave evidence to your committee. There is no doubt that many practitioners have invested in their own training and are committed to providing a safe and professional service to their clients. I know many of you will have constituents in this sector and that these are often small, female-led businesses. I think there is room for a thriving non-surgical procedures sector, an important continuing role for non-healthcare professionals in that sector, but with some changes to current practice to support safety. While public safety is my priority, I have always been clear that we should not put in place a disproportionate burden on businesses. I am comfortable that the provisions in this bill are the least as restrictive means of achieving the bill's aims. Many experts and many respondents to our consultation have wanted to see a more restrictive approach than provided for in the bill. In many countries where procedures such as Botox or derma fillers have been regulated, these may only be carried out by doctors or by doctors, dentists and nurses. However, under our proposals, I considered it appropriate that non-healthcare professional practitioners can continue to provide procedures as long as they do so in a permitted premises where services are provided or managed by a healthcare professional, and I will come on to training and qualification standards shortly. I've also ensured that procedures are only included in this bill where absolutely necessary. Lower risk procedures that do not require to be undertaken in a setting which involves a healthcare professional will be included in a local authority licensing scheme akin to that in existence for tattooing and skin piercing. I also know that you have heard evidence about the importance of training standards for practitioners. I am happy to reconfirm the Scottish Government's commitment to establish training standards for procedures in the bill. Unfortunately, legislation setting these standards would engage Part 3 of the UK Internal Market Act. I'd be happy to discuss this in more detail, but for the time being, I want to assure the committee that while these provisions are not on the face of the bill, the Scottish Government is engaging with the UK Government with a view to finding a way of implementing training standards in a way that will be both effective and workable. The final issue to raise in relation to Part 1 of the bill is to highlight to the committee that last week an order was laid under the Civic Government Scotland Act in draft for Parliament's consideration. The order, if affirmed, will establish a licensing scheme for lower risk procedures which do not require to be carried out in a setting which involves a healthcare professional and therefore do not merit inclusion in this bill. The scheme established by the order and the provisions of this bill are intended to work alongside each other to provide a comprehensive regulatory regime. I should also confirm that the order sets a date after which businesses will have to comply with the licensing scheme. I've not previously provided a date that we intend the offences in the bill should come into force, but I'd like to take this opportunity to set out my intention that the bill come into force on the same day that the licensing scheme becomes operable, which will be the 6th of September in 2027. And I look forward to answering your questions. Thank you.
Thank you, Minister, and we will move straight to questions. And Sandesh Gohani.
Thank you. Declaration of interest of practising NHS GP. Good morning, Minister. Thank you for coming. I have quite a lot of questions to put to you. And my first question is about the definition of regulated healthcare professionals and the list of councils that has been provided. The General Osteopathic Council, the General Chiropathic Council. Why are they in the list and are they necessary?
So when we were creating the list of professions that we felt were appropriate, we wanted to understand their qualifications in both prescribing and also understanding the impact that prescription, that using the items that they could prescribe, if they had negative impacts, then how could they mitigate against anything going wrong?
So an osteopath would be able to prescribe Botox then?
Can I?
Absolutely, yes. So it's not our understanding that osteopaths are currently involved in any kind of prescribing activity. The list you're referring to is the list of professions related to the healthcare exemption within the bill. That's been a broadly drawn list to ensure that no, I hesitated the word legitimate, but no kind of healthcare activity that you might expect to be associated with that list of professions is inadvertently excluded by being captured by the offences within the bill.
Could you give me one example of an osteopath that would be in the that would be a procedure that they would undertake here that would be exempted?
So we are not currently aware of any procedures being undertaken by osteopaths that would be captured by any provisions in the bill. We've reconsidered this since this committee took evidence on this a few weeks ago. We can provide examples for some of the other healthcare professionals, the Chiropractic Council or the HCPC, but we're not aware of any current activity that osteopaths undertake in doing injections or other procedures that might fall under the bill. If they were to be excluded, however, from that list, I think further work would need to be taken, including with the council themselves, to ensure that nothing was inadvertently excluded.
I'm sure my colleagues might come onto this. If I could move on a little bit, please. Minister, you spoke about permitted premises being very important. When we had a dentist in front of us, they spoke about how not all practices are HIS inspected, and it depends upon your NHS and your private work, whether there is any private done in the practice. So how would we ensure that dentists and dentist premises would be captured in this?
So, as you point out, dentist practices that provide NHS NHS services are covered by NHS regulations. Therefore, the permitted premises we would expect to be hygienic and adequately staffed, and that's in line with what you would expect for NHS inspected and registered and regulated premises.
Okay. There is the word supervision in the bill. So the question that I think a lot of us had was, what exactly does supervision mean? So, for example, if you have a prescribing doctor and they are supervising people, do they need to be in the room during the procedure? How many people is appropriate? Could you have a doctor supervising 100 people, say, or is there a limit to that?
Yes, thank you for raising that question, because I sat and watched the evidence and recognised that the definition of supervision was something that was playing on a lot of people's questions and thoughts. And I think, as I highlighted in my opening statement, we haven't put that on the face of the bill, because we are still in discussions with the UK Government around UKEMA, because it is the view of the Scottish Government that Part 3 of the UK Internal Market Act would be engaged by legislation that sets training standards in this area. And we want to be sure that we have the right conversations and make the right decisions around training and also supervision. And so therefore that will be included in Schedule 5 of the bill, which allows us to take out secondary guidelines or secondary legislation on this.
Do you think you might be able to bring that maybe at stage 2 or 3?
What I can say is that our conversations with the UK Government and the work that we're doing with them has been progressing. It is with both the Business Department, who specifically look after the trade, but also the Health and Social Care Department as well. I will be writing to the UK Government probably later this week to see how we can move on with them. But sadly, I think it's one of the unintended consequences of UKEMA has meant that we could no longer make specific decisions around public health, which we could have done when we were part of the European Union.
Okay. So we heard about people going underground and doing things illegally, which is illegal. Yeah, that's the whole point. But should practitioners not complying with the law be billed by the NHS for mistakes, errors, complications that they cause, forcing people to come into the NHS for help?
So I think that's a really interesting question, Dr. Glahani, and something that has preyed on my mind since the first round table that I was at, and it was very clear at that time that there is no current way of specifying within records as to how an impact occurred. So, for example, there's no record within NHS records that says that something was specifically done because of a Botox injection or whatever, which we did work on to see if we could shift that, to change that. But I think the whole reason that we want to regulate and bring this in is to ensure that we have better records as to the impacts as well, which is some of the regulation work that Healthcare Improvement Scotland will provide.
I know time is short, so I'll get to my last question now. A lot of people, when you go to the shops and you buy paracetamol, you expect paracetamol, Panadol to essentially be the same thing. They are drugs which work and are regulated. We know that Botox is not Botox. There are people buying it from all sorts of different places. We also know that people's training isn't the same. So if you go to a doctor or a pharmacist or a nurse, you know there's a basic level of training expected. So that's something that I'm very keen for this bill to ensure occurs. But one of the things that we heard at the very outset, one of our first sessions, was a practice that would remove skin moles and skin lumps. And the overriding regulator, person who looked at these lumps and said, oh, well, this is cancer or isn't cancer, wasn't a registered nurse, wasn't certainly a doctor. And my fear is if there's no path lab that lump is being sent to, and you know, I did orthopaedics for many years, I wouldn't be allowed to just whip out a lump on my own. With no supervision or the consultant knowing about it, and I've been trained in surgery for a very long time. And you wouldn't see somebody that's not a professional, that isn't regulated, for a lump, for a mole. You just wouldn't do that. So is that going to fall within the provision to ensure safety, that people aren't having cancers removed?
So I think you also heard in your evidence from one of the practitioners that if they had any concerns that it could be cancerous, then they would direct their client to their GPs, which I think is the right thing for people to do. And I think you raise a really important point, and one that I'm happy to ensure we take away and think about, because that absolutely falls into the safety element of this bill, the public safety element of this bill. And I think as well you took a lot of evidence around educating the public as well, and I think your question fits into that, but very happy to take away that to ensure that we've taken proper consideration of what you've just said.
Thank you.
Joe Fitzpatrick.
Thank you. Minister, I'm wanting to go back to Sandesh Gulhani's question around the regulated professional bodies and the inclusion of the General Osteopathic Council and the General Chiropractic Council. My understanding is that neither osteopaths or chiropractitioners are medically trained in this country. They are in some other countries, and I'm not aware of their ability to therefore prescribe pharmaceuticals. So it seems that they are ajar. When asked about which procedures they might be covered for, we weren't given an answer. So I'm really concerned that we are potentially having a loophole which would cause confusion, where people could think that for some reason, because those regulated by the General Osteopathic Council and the General Chiropractic Council are covered, that they somehow have the ability to perform the procedures which are outlined in this legislation. And I don't think there is any reason for that. So I would really ask you to consider whether those two bodies should be removed in order to make sure the bill is as clear as possible, given we weren't able to come up with any reason not to.
Sure. I thank Mr Fitzpatrick for pressing on that. And I think we've always been clear when we've been drafting the bill that there is a difference between healthcare need and also the aesthetic wish to have these treatments. Now, if I can go back into my past life, I used to work with the BBC Scottish Symphony Orchestra, and there was 2 players in there that had specific issues with their ability to play, and both were prescribed Botox injections. So I think we need to be clear from a healthcare there is that need. Also, children living with cerebral palsy can also get Botox injections. So we need to ensure that that element of healthcare is not lost. With regard to a chiropractor and joint pain, there is often there could be an injection for hyaluronic acid to reduce pain, which is another area. But I'm content to, given that it's been raised by both Dr. Gulhani and yourself.
I would appreciate if you would do that, because I think if someone's got cerebral palsy, then and they require those injections, then they should be going to a medical practitioner to receive it.
Yeah.
And I'd be concerned if routinely people are receiving medical treatment from people who are not medically trained. And neither of these bodies, I'm not criticising the work they do, but neither of these bodies are medically trained individuals. And if we are inadvertently giving the public the indication that they are somehow medical practitioners, then I'd be really concerned about that. And I think, so I'm grateful for your agreement to go away and look at that again and see whether these two groups perhaps should be removed from this.
And given the underlining of this bill is to protect public health, I'm very content to look away at that.
Thank you.
Excuse my voice disappearing.
Thank you.
Emma Harper.
Thanks, Convener. Thanks, Convener. Good morning, Minister. Just on the back of Joe Fitzpatrick's question and Sanjesh Kulhani's, the hyaluronic acid is a dermal filler that is registered as a medical device by MHRA, whereas the antidote, hyaluronidase, it has to be prescribed. So there's a bit of an issue there if osteopaths who are not medical trained, but they don't prescribe, but they could give a device. Does that create a problem? And if so, what work is being done with MHRA in order to look at how we regulate the device that's actually not a device, it's something that's been injected, that's maybe really a medication?
Yeah, so as you'll know, Ms Harper, the MHRA is reserved, and I think you've just highlighted the exact area that we are trying to cover, in the fact that you need a healthcare specialist there in case something goes wrong, and that's been the premise of the permitted premises with the right qualified staff, and also with the regulation from Healthcare Improvement Scotland. But as I responded to Mr Fitzpatrick, very happy to ensure that we can provide you with further information on that.
Does it mean that if somebody's going to administer a dermal filler, that they need to have the antidote on site in case, because time is really a critical issue if somebody's blood supply to their upper lip has been injected instead of the tissue around it. So that would mean that this antidote would need to be readily available at whatever site is determined to be a Healthcare Improvement Scotland clinic. That was a lot of issues.
So, if I've understood you correctly, because the antidote is a separate prescription, then you are saying that that needs to be held on the premises to ensure the timely intervention, which is exactly why we are saying that we need healthcare clinician specialists on site when these procedures are being carried out. I think Owen's championing at the bit to say something else.
Just to, sorry, to add to that, what you've described there is, as we understand it, standard practice in his regulated settings where dermal fillers have been carried out for cosmetic reasons. It would be very usual for them to hold stocks of hyaluronidase, and currently where his is regulating that, they would expect somebody who to be available on site who is capable of making that prescription at the time where the procedure is being carried out. So that standard procedure currently in that regulated setting, what the bill does, of course, is bring those procedures into that regulated setting, so that could continue to happen. I hope that's helpful.
Okay, thanks. Thank you.
So if I can just backtrack a little bit as well to part of one of Sandesh Gohani's questions, which was on supervision. And I may have missed the answer to that, but I'm not clear on that. I think Sandesh Gohani asked about how many people can a healthcare professional supervise in relation to particularly supervision. And so I'm keen to hear, because it was a question that's been raised with the committee, an issue raised with the committee by several panel members previously. So what exactly does that mean?
So, as I said to Dr Kulhani, we are still in discussions with the UK Government to understand what we can actually do as a result of the UK Internal Market Act. And certainly when HIS are regulating specific businesses, they have a clause that says they need to be appropriately staffed. So the work that we are doing on supervision is in parallel with his Healthcare Improvement Scotland and also with the work that we're doing on UKEMA. At this point in time, I can't say how many people it would be required to supervise. That will be worked through once we understand the level of training and the level of qualifications, and also the regulations that Healthcare Improvement Scotland will deem appropriate to ensure we have proper, robust regulation of these businesses.
Okay. So in terms of how things currently are, from what you and Mr Griffiths have said, if there is a procedure like derma fillers, Botox being carried out in a HIS-regulated setting, there will be a prescriber there who can, at that point in time, step in and prescribe an antidote or an appropriate treatment if things go wrong. But if you have a single practitioner who is carrying out some of these procedures in either in a room in a beauty salon or a hairdresser salon, or in their own home, whether that be inside the home or outside the home, they wouldn't currently have access to a healthcare professional to prescribe something at that point in time. So would you anticipate that if this regulation or if this bill is passed as drafted, that would mean that someone who was a sole practitioner would not be able to become HIS regulated to carry out these procedures?
So there are a few things there. In the HIS regulation will also look at the premises to make sure that they are safe and hygienic.
Sorry, I appreciate that, yeah. And I'm sorry for interrupting you, Minister. It's specifically about the supervision element of this. So I'm just trying to get my head around that. Whether there would need to be someone there on site who could prescribe an antidote or a remedy to relieve a complication. So that, as Mr Griffiths has said, is the situation that is currently the situation with HIS regulated premises. We are currently working with looking at this to see if that would be the actual requirement from and it's the balance, I suppose, between ensuring that each place that people can go for these treatments are as safe as possible. Paul Sweeney.
Thank you. Thanks to the Minister. The committee heard last week that only wholly private dental practices are HIS registered, while oversight by NHS boards applies only to practices which provide NHS dental services. How will the bill ensure consistent regulation of Schedule 1 procedures delivered in dental practices, and what measures can the government take to ensure that there are no gaps in assurance where HIS oversight cannot be assumed?
I think that's a really important question, and one that we will be discussing in more detail with HIS. It is important, and this is one of the key elements of the bill, is that premises are properly regulated, are hygienic and are safe, and that's the work that we are currently doing with HIS.
Brian Whittle.
Thank you, Convener. Good morning, Minister. I'm looking at training and training standards. If I could, you'll be aware there's quite a lot of stakeholder call to set minimum training standards and mandatory qualifications for all practitioners. That would be medical and non-medical alike. How would the government respond to those calls?
I'm really sorry I didn't hear your question. You were speaking through your hand.
Sorry, I do apologise. I'm just saying that there's been calls for sort of standard or minimum training standards and mandatory qualifications for all practitioners. And I just wondered how the government would respond to those calls from stakeholders.
I agree that there needs to be training standards, appropriate training standards. And as you will know, the bill doesn't cover standards on the face of the bill or supervising requirements, but it is, in my view, really important that we get the right training for people and we get them properly regulated, and that's something that I see as important for government.
I think from a practical, we would agree with that. But from a practical perspective as well, we heard quite a lot around the sort of ability to have a day or a couple of days courses, and all of a sudden you're qualified. Would you envisage the bill potentially, over time eradicating that kind of inadequate training?
So one of the areas that I'm clear on, and that's part of the conversation that we're having with the UK government through the UK Internal Market Act, is that we need to have a proper standard for qualifications. I think in the evidence that was provided to you that there's a course at the University of the South of Wales. We haven't yet engaged with them, but we are planning to. We have also We also understand that there are a couple of universities in Scotland that are looking to provide better courses or accredited regulated courses that would help ensure that people that are offering these treatments have got the right training and qualifications.
Well, I wonder how would you define what approved training providers and what the curriculum would be. How do you plan to provide that? And is there a role for the Scottish Qualification Authority in setting these standards that are related to the bill?
So it may well be a role for the SQA. It may also be a role for specific universities to do that.
Okay. I mean, one of the things, the risks or the unintended consequences potentially of the bill was that those practitioners with high-level aesthetic qualifications may be prevented from practising, while you have a nurse with maybe no off-qual recognised training, would be permitted to carry out regular procedures. So, how does the Scottish Government intend to mitigate that risk?
So that came very clearly through evidence that you've taken and also meetings that I've had where there are practitioners that have qualified up to level 7.
Yeah.
That's one of the areas that we will be looking at as to how do you shift, if I can describe them as credits, from that type of training and how that would fit in with the regulated training and qualifications we've just been talking about.
Just as an aside, do you see that being on the face of the bill, or would you presume to do that in secondary legislation?
Currently, the plan is for that to be in secondary legislation.
Okay, thank you. And just finally, from me, you mentioned work with the UK. Can I ask what sort of consultations you have had with the UK nations in sort of that mutual recognition of training qualifications, so that we have a level playing field across?
Yeah, so that's part of the conversations that we have been having with the UK government. Owen and other officials have been speaking directly with officials so that we understand the impact of ensuring that qualifications can be as consistent across the 4 nations and reach the appropriate standards to ensure that you've got public safety across the United Kingdom.
Thank you. No more questions, Convener.
Thank you. Carol Malkin.
Good morning, Minister. I want to just raise a little bit about public awareness, and we have heard evidence, and I know you've spoken in the past about it. Just what do you think will need to come along with this bill to raise public awareness of the dangers, but also of the reputable people out there practising?
Yeah, and I think when any legislation comes into place, you need to have appropriate public messaging and engagement. And I think that was made very clear through evidence that you received from Mr White about that communication with people. Now, we haven't specifically set out a communication plan. Clearly, that is something that we will work on if the bill is passed to ensure that the right people get the information. I was asked if I would front the announcement of the consultation. I didn't think somebody in their late 50s now was perhaps the right person to do that. So we have to make sure we're targeting any information out to the public the right way, using channels that people can access.
Great, thank you. I wonder, just on a similar sort of discussion, how do you think we can combat perhaps advertising, marketing, I suppose, that maybe trivialises the procedures, makes it seem that it's not actually a medical procedure? Do we have a plan for that?
Yeah, so not with regards to this part of my portfolio, but with regards to other parts, I have met with the Advertising Standards Agency to talk about advertising on social media around smoking and such like, and vaping. As you will know, that Advertising Standards Authority are reserved. So again, that is an area that we would be looking at, working on and working with the other governments across the UK.
Great. That was part of what I was going to ask about as well, but I know you've committed to that in the past, which is really helpful. One of the last questions I have is just around, I think you probably were indicating that we know younger people are attracted sometimes to this, and the age limit is set at 18. I just wanted to know, do you think that we will need to have some campaigning around making sure that younger people are aware of the procedures and the pros and the cons? And there was some talk about a register of licensed practitioners. How do you think that will work, and how do we make sure that people are aware that there is a register?
I think public awareness is one of the biggest things that every single one of us as elected representatives in Scotland can support the Scottish Government on, and also support the public. I think it's important that people do understand the possible negative outcomes of receiving treatments like these from unregulated practitioners, and that is certainly something that I would be focusing on if the bill is passed.
Okay, thank you. Thank you, Convener.
Patrick Harvey.
Thank you, Convener. Good morning. Just to follow up on the questions about public awareness, could I maybe draw out a little more about what the government's attitude is to the balance between the responsibility of the public sector to provide public awareness information and the responsibility of providers to provide information? When we talk about other products on sale that have some health harms, we do both. We don't simply say that providers have to give information. We don't simply say that there's a public health awareness campaign. We do both. I'm not quite clear whether the Scottish Government is saying that it wants to regulate the information about risks that providers of these procedures have to make available. I recognise that in terms of advertising that might be reserved, but if it's about regulating the provision of information about risks, surely that's a public health matter and therefore devolved.
I think you ask a really interesting question, Mr Harvey, and I think there is I would envisage any messaging that comes from a public health perspective to display the negativity and the risk of doing something. And so I'm just thinking back about the work that we've been doing for the tobacco and vaping bill with regards to ensuring that, and I think this is perhaps what you're getting at, the fact that it's the onus is on manufacturers to provide that information on their packets, for example. Yeah. So I think that's a really interesting concept and way forward that we would certainly explore.
I mean, tobacco is an interesting comparison because we don't simply require the provision of information in text form, but images as well,
yes.
And sometimes quite shocking and deliberately so. Is that an approach that you would expect to explore in relation to the provision of these procedures?
I'm certainly content to explore it because I know from my own perspective, seeing the impact of bad procedures really shaped a lot of my thoughts on this.
Thank you.
David Torrance.
Thank you, Convener. Good morning, Minister and officials. My question is around the impact on businesses. How will the Scottish Government ensure there is a clear guidance for the practitioners and businesses on the compliance requirements set out in the bill?
I think that's absolutely key to ensuring that the bill works. We have to make sure that businesses absolutely are clear on what the requirements are. And I think if you look at businesses that are currently regulated by Healthcare Improvement Scotland, you can see the clarity on their websites and in their premises that show the additional regulation that they have.
Minister, what's the timeline for the bill coming into act if it's passed?
So if the bill's coming into is enacted, as I said in my introductory note, we have just laid an SSI on the licensing for Group 1 of the procedures, and on that it says the 6th of September 2027. So we would envisage the bill to come into force then as well. That gives more than a year, assuming the bill is passed, for businesses to comply with regulations and ready themselves for these regulations.
What work is the Scottish Government undertaking on assessing the financial impact and viability on small businesses as a result of the bill, and what practical and financial or advisory transitional support will be available for practitioners to help businesses meet the new requirements under the bill?
So we've engaged a lot with small businesses because we do recognise that this regulation will have an impact on certain businesses that are carrying out certain of the procedures listed. We've been speaking to various areas within government, within the business elements of government, to see what support could be provided. And I think there is a bit more work that we can do in that area, just looking at what support businesses may need, whether it's through the Small Business Federation, for example, and other areas. But these are conversations that are most definitely ongoing, because I do recognise we have to get the balance right.
The final question, Minister. How will the Scottish Government ensure the implementation of the bill does not push treatments underground with associated risks and reducing safety and choice?
So this is one of always one of the concerns when you bring in regulations, and I think I have been asked as to whether we're bringing in these regulations too late, and I responded by saying that with regards to safety of driving, then it wasn't too late to bring in seat belts when in cars. So I think it's absolutely important that we recognise that we need to regulate an area to improve public health and safety, but we also need to enforce that well, which is why we've been working both with Healthcare Improvement Scotland and the environmental health officers as well.
Thank you.
Can I ask, Minister, do you have timescales around about when you would expect businesses to comply with new regulations?
So we've said that we would bring the Act into enforcement on the 6th of September 2027. I haven't had any conversations with officials as to if there would be what's the word I'm looking for? A phased introduction, but very happy to come back to the committee with regards to that.
Okay, so that is perhaps something that you might consider. And with regards to enforcement, would Scottish Government adopt an improvement first approach rather than immediate punitive measures for non-compliance of businesses?
So I think I'm right in saying that the evidence that you received from Healthcare Improvement Scotland was described that process in that they would inspect and give recommendations and then re-inspect. And I think that is an appropriate way to move forward, but clearly with the caveat it would depend on what had gone wrong and what was being investigated.
And in terms of, if an improvement notice was served to a business, how would you envisage that business would be supported to improve its standards?
So my understanding is that Healthcare Improvement Scotland are there to support as well.
And are you confident that Healthcare Improvement Scotland has the capacity to do that?
So that is clearly you got evidence from Healthcare Improvement Scotland last week as to the capacity that they may or may not have. And that is one of the ongoing conversations that we have with them as to how they will provide the regulation and enforcement work that we envisage from this bill. Clearly, as businesses register, then they will pay a registration fund fee, a one-off, and then a regular one every year. And our aim is that Healthcare Improvement Scotland does become self-sustaining financially as a regulator. And these are ongoing conversations that we are having with Healthcare Improvement Scotland.
Elena Whittam.
Thanks, Convener. And following on in the enforcement theme, I want to focus my questions around about the unregulated side that we know is going to be created in this instance. So we've heard concerns that the bill might not give HIS sufficient powers, systems or resources to be able to undertake effective enforcement in unregistered settings. So what additional resource and support will Healthcare Improvement Scotland receive to enforce the bill's provisions effectively, given the scale of the expectations that are upon them? So in the regulated setting, but also in the outside of that regulated setting where we might see those rogue traders underground.
So the bill does give HIS the powers to enter unregulated settings if there have been specific complaints made or evidence given to them. Around the resourcing, as I responded to the convener, we expect Healthcare Improvement Scotland's regulatory services to be self-sustaining financially, so that is part of our ongoing conversations with them. I do recognise the point you make. If you've got an unregulated business, then they're not paying for these regulatory people. So therefore, that's something that I'm content to ensure that we can bottom out if we get through stage one, so we can look at that from stage two.
And what do you foresee being the balance between the kind of proactive approach and a reactive approach? So how much of their work is going to be done in that way of going out and regularly inspecting and reacting to intelligence that's giving, and how's that balance going to be struck?
So, as you know, Healthcare Improvement Scotland are independent of government, so therefore the intention would be that they work out the best way of ensuring that they are inspecting regulated premises as often as they need. There are similar models that Food Standards Scotland do as well to ensure that, and also environmental health officers, to ensure that premises are properly regulated.
And if we think about, all of the players that maybe need to be involved. So you've mentioned environmental health officers in terms of the licensed aspect of this. Is there also a role for Police Scotland to be involved in here if we think about counterfeit products and maybe those things that are going to start happening, or we know they happen already, but what will happen on that black market in those unregistered premises?
I would expect all health and safety agencies, including Police Scotland, to be working together. I referenced Food Standards Scotland. They have had a number of very successful forays into unregulated products on the market from a food perspective, and that is done very much in partnership with Police Scotland.
Okay, and I think it would just be helpful again to have it on the record in terms of a route map being published in the lead up to the regulations coming into enforcement. Is that something that you're content to go away with, so that the industry themselves have a staged understanding of what is expected of them and at what point, so that there might be the element of education, there might be the scaled up improvement notices that are expected. Is that something that you're content to look at?
I think from when any new piece of legislation comes in, I think there has to be that route map to it being fully implemented, and so I'd be very content to take that process away from education of businesses, education of the general public, and if we do need a phased implementation.
Thank you.
Paul Sweeney.
I just wanted to ask also about incentives. There's a side of enforcement, but also incentives. There was concerns raised by practitioners about the burden on training costs, for example. Could there be a scheme of incentives created through support for grants for small business owners to access training and accreditation if there is mandatory requirements or new standards created, so that there's a positive as well as a negative effect?
And I think Paul Sweeney raises a really good point around how we ensure that businesses that are good businesses reach the right standards to ensure that they can undertake the right regulatory regime that we are introducing. As I referenced to somebody else's question, it may have been the convener's questions around the support for businesses. That's something that we have been actively looking at while we've been drafting the bill, and will continue to do so and take on board the points that you've raised there around incentives.
Okay, thanks.
Patrick Harvey.
Thank you, Convener. Just to follow up the enforcement theme, the offence that the bill creates is around providing the procedures that are covered in the bill out where the permitted premises. It doesn't include an offence of offering those procedures in those circumstances. Are there any existing offences that would come into play in relation to offering procedures in that way? Offences that could play a role in enforcement? And the powers to inspect premises or powers of entry and so on also come in where there's a reasonable belief that the offence of carrying out the procedure has been or is being committed. Again, where procedures are being offered or the offer to make them available can be demonstrated, but there's no evidence that it's actually happened. Again, is there another way to allow enforcement authorities to exercise that power of entry?
Can I turn to Rachel from a legal perspective?
Thank you. Yes, so the offence is for providing the procedure, and in criminal law, where that offence happens will determine where you are in the stage of what is happening. So it really will depend on the facts and circumstances of that case. What we might need to do is go away and look into that a bit further, and about where the actual offence would happen.
So in a situation where somebody, for example, on social media is making the offer, even just within a friendship group, to provide those procedures out with permitted premises. Is there anything in the bill or anything currently that would allow enforcement action to be taken?
That's so it would depend, and I would need to go away and look in specifically about where the two elements of an offence would happen.
Okay.
But at the moment, it is about the provision.
Yeah.
At that point, it takes place. But
if there's anything further that could
yeah.
be provided in writing before the bill progresses, that would be helpful.
I'm going to briefly suspend the meeting so that we can change witnesses for our scrutiny of Part 2 of the bill. Welcome back, and we'll continue our evidence session with the Minister for Public Health and Women's Health on the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill, focusing on Part 2 of the Bill. Supporting the Minister on Part 2 of the Bill is Katrina McNeill, Team Leader, Burial and Cremation, and Lucy Oren, Lawyer from the Scottish Government. And Minister, I believe you have a further statement.
Yes, thank you. Thanks, Convener. I'm pleased we're also considering 2 amendments to the Certification of Death Scotland Act 2011, which will extend the right to request an interested person review and amend the provision concerning the authorisation of cremation in Scotland where the death occurred elsewhere. The extension of interested person reviews under the 2011 Act represents an important step in strengthening public confidence in the death certification process by allowing all relatives equal standing in being able to request an interested person review. Medical reviewers already undertake randomised reviews to improve the quality and accuracy of medical certificates of cause of death. Where a randomised review has taken place, an interested person review cannot be carried out. This amendment allows individuals with a legitimate connection, such as family members, healthcare professionals or funeral directors, to request a detailed review where they believe further scrutiny is warranted. It will mean such interested persons can request a review irrespective of whether a medical certificate of cause of death has been randomly selected for review already. By enabling further targeted reviews, all bereaved families will have the same right to request a review. The system will be more transparent and responsive, ensuring specific issues can be examined thoroughly and sensitively. Ultimately, it enhances accountability and provides an additional safeguard to reassure both the public and professionals involved in end-of-life care. Section 18 of the Certification of Death Scotland Act 2011 currently applies to deaths occurring out with Scotland. This includes deaths in other parts of the UK, creating a legal requirement for medical reviewers to authorise cremation in Scotland where a person died in England, Wales or Northern Ireland. Other UK nations have robust procedures in place regarding death certification and apply relevant checks, and it is appropriate that these are respected for cases where it's intended that the deceased is to be cremated in Scotland. The amendment removes the need for medical reviewers to authorise cremation where a death occurs in another part of the United Kingdom, recognising the reciprocal checks in other parts of the United Kingdom and avoiding unnecessary duplication of work. In conclusion, both the extension of interested persons review and the amendment of Section 18 of the 2011 Act reflect our continued commitment to clarity, transparency and public trust in the death certification process. These changes not only strengthen safeguards for families and professionals, but also ensure that our legislation recognises existing robust checks and procedures and is responsive to real-world practice. I therefore propose that the committee recommend the extension of interested person reviews and the amendment concerning the authorisation of cremations in Scotland where the death occurs out with Scotland, and I look forward to answering any questions the committee may have.
Thank you, Minister, for your further statement, and we'll move straight to questions again. And Paul Sweeney.
Thank you, Convener. Thank you, Minister. First thing I'd like to ask is what resources will the government put at the disposal of registrars and the death certification review service to ensure that they have sufficient capacity to handle what will clearly be an additional workload?
So, Can I pass on to Katrina? I'm sorry.
So, currently for interested person reviews, they're a very low number. There was only 6 in the last year. And Death Certification Review Service have confirmed they do not anticipate that there will be a huge increase in numbers going forward if the amendment's passed, and can absorb that into their current workload.
That's helpful. So you don't envisage any additional workloads having an effect on timeliness of burial in these cases?
No.
Okay. To prevent misuse and delays, what timeframe would the government expect to be able to publish the clear criteria and guidance for accepting or rejecting review requests?
Sorry, so that would be an operational question for the Death Certification Review Service. Their random reviews are normally done within 1 day, and interested person reviews would be very quick, maybe 1, maybe 2 days. But we wouldn't issue guidance on how they would do that. They already know how to do that, and they don't need any further guidance on that.
Okay. Has the government considered a transparent appeals process for declined requests for reviews?
I'm not aware of any process to decline reviews.
Okay. And also just to reinforce confidence in certification, as part of these reforms, would the government reconsider the current exemption from review for medical certificates cause of death where the death has been investigated by the Procurator Fiscal?
I'm sorry. Yes, please.
So, do you mean the current exemption from an interested person review?
Yes, so it's an exemption from review for MCCDs where the death has been investigated by the Procurator Fiscal. Would that be something you would look at?
We could do. It's not something we're aware of there being any call for. The Crown Office can investigate the whole circumstances around a death much wider than just what's related to the MCCD. So, but if there was a need for that, we could certainly consider it, and we'd be happy to engage with you further if you wanted to discuss that.
Okay, that's helpful for the committee to think about. And also, in terms of provisions on interested person reviews being supported by national guidance and appropriate public communication, what practical steps are you thinking of undertaking in terms of national guidance and communication of these changes?
There is the Death Certification Review Service Statutory Guidance, which is published, and we could update that to ensure that if the amendment is passed, it's clear what circumstances the interested person review can be asked for.
And is there a public interface for members of the public to understand these changes?
It's on the Healthcare Improvement Scotland website, yes.
Okay, that's helpful. Thank you.
Thanks. Just picking up on that theme.
Sorry.
Just picking up on the theme that Mr Sweeney has just been looking at there in terms of public awareness of their right to ask for a review. How are you proposing to ensure that that's more widely known?
So, as I said in my introduction, this isn't a change in the fact that people can have reviews. That's always been there, that people should be aware or be informed that they can do this. What this change is to ensure that those that have been randomly chosen for review, that then does not stop a member, a connected person, whether it's a member of the family or a healthcare professional, from asking to review that statement. So the knowledge that people can review is already there. I think maybe what I take away from this, though, is that perhaps it's not widely enough known. So therefore, maybe that's something that we should take away and review.
I think you're correct there, Minister. I don't think it is something that is widely known. Well, this is a very small proposed change to the legislation. I think it gives an opportunity for that information to be disseminated a bit more widely, so that members of the public, in particular, healthcare professionals and funeral directors, are perhaps more au fait with that part of the legislation. But of course, that may then have the knock-on effect of then there are more requests for reviews.
Agreed. Yep. Agree on both points that you're making there, Convener.
So I suppose moving on a little bit to the cross-UK cremation authorisation part of the proposed legislation. So how confident is the Scottish Government that the bill ensures clear, consistent processes when authorising cremations that have occurred or that the death has occurred outside of Scotland?
So as I noted in my introductory remarks, each of the four nations have got robust procedures, and therefore we are taking note of that and operating in a way that gives that consistency across the four nations.
So you are confident with
Yes, I'm confident.
So, and what data sharing and governance arrangements would Scottish Government expect to be in place across the UK jurisdictions to protect privacy and ensure accuracy?
So, from the Scottish Government's perspective, we have got clear guidelines for funeral directors around that. If I can touch on, Katrina, if you can add a bit more to that.
So, The information sharing between the organisations like the Death Certification Review Service or the Coroner's Office in England and Wales will comply with data protection legislation. The Scottish Government and ourselves, we don't actually see any of that information, of people's personal medical records.
Okay. And do you foresee the DCRS handling exceptional cases like repatriations and ensuring equivalent checks have taken place elsewhere?
Yes.
Yes.
Okay, well, you're very clear, clear on that. And how will Scottish Government monitor and evaluate implementation, quality and timeliness across jurisdictions? Do you have plans for data gathering, report publishing?
If I can tell, yes.
So I'm a member of the DCRS Management Board, which meets quarterly, and we discuss all those kind of issues at those quarterly meetings. And we also have 6 monthly meetings with DCRS about their operational procedures, where we can engage in all those points at those meetings.
Okay, and you envisage that those will continue?
Yes.
Yeah, if the legislation is passed. That's the end of our questioning this morning, Minister. Thank you to yourself and to your both sets of officials who have attended today. This is the final meeting of the Health, Social Care and Sport Committee in 2025. On behalf of the committee, I would like to take this opportunity to thank everyone who's contributed to our work this year and to wish everyone a happy and restful festive period. And that concludes the public part of our meeting today.
Thank you.